One trial I'm also very excited about is the ECLIPSE trial. This is a trial of coronary atherectomy versus a conventional balloon-based strategy for patients that have severely calcified coronary arteries. We know that coronary calcium really is not something we like dealing with in the cath lab because it can increase procedural complexity, time, and even complications, not only in the lab, but also over the follow-up period. But we don't know definitively what the best way to treat these patients is. Do we do balloons or do we do atherectomy devices? Many experienced interventionalists are very familiar with atherectomy devices, but the guidelines really can't afford any recommendations because we don't have hard data. So this is a 2,000 patient randomized trial to determine which strategy is more effective at opening these arteries, both from the standpoint of acute issues as well as later term outcomes. Another study that we're actively enrolling in that we're quite excited by is a trial called the OPTIMUM Registry. And this is a registry explicitly looking at patients referred for angioplasty and stenting who have been turned down for coronary artery bypass grafting. There are many patients that have disease that's so severe or interventionalists not well trained enough to treat them that they're told there are no options or that they're too high risk for anything. At a referral center like ours here at Columbia NYP, we get patients like this and we're asked for second opinions, and yet we can treat these patients with coronary revascularization procedures in the cath lab. But what we want to do is make sure we're doing it effectively, safely, and to determine how much of an improvement these patients get from doing these procedures. And so we're studying this in all of our surgical turndown patients in this registry, which asks patients what their quality of life is, both before and after the procedure, ascertains the safety of the procedure, also the efficacy of the procedure, so we can better understand how these patients do with the higher risk coronary interventions that we make.